Hello, everyone, and thank you for joining us on this episode of the Account and Coca Report. As a reminder, we put out an episode of this show twice a week, and we've been bringing to you great guests with great insights on healthcare and medicine for almost 4 months. So make sure you subscribe to the show on your favorite podcast app or on YouTube. Our topic today is the Canadian healthcare system, as seen through the eyes and experiences of a doctor. What is the life of Canadian doctors really like? Are they so constrained by the single-payer system that all they can do is show up to work, put in their hours, and let the bureaucrats decide everything about resources, doctors' pay, and wait times? To help us gain a realistic understanding of the Canadian system, we have as our guest Dr. Shawn Whatley, who currently runs a primary care practice in Ontario, Canada. Prior to this position, Dr. Whatley worked for many years as an emergency physician, and he is the author of No More Lethal Waits, 10 Steps to Transform Canada's Emergency Departments. Dr. Whatley is past president of the Ontario Medical Association, and he is a senior fellow at the Macdonald-Laurier Institute for Public Policy in Toronto. He also publishes a highly trafficked blog where he shares insightful and humorous comments about healthcare in Ontario. In other words, he is the perfect guest to inform us about the realities of healthcare in Canada. Shawn, welcome to the show.
Thank you, Michelle and Anish. That's great.
Great having you. Before we get going, I want you to correct me to the audience, because I was corrected by a Canadian physician when I mentioned the Canada's healthcare system in the singular. On Twitter, somebody came back at me and said, "No, there's no one system. There are systems. Every province has its own system." That's correct? And how different are they? Are they so different that we can't really say anything more generally about Canada's healthcare system, or are they similar enough that go ahead.
If you want to be rigid about it, there's definitely more than one system. So each province has its own take on things. However, the overriding principles are common from coast to coast. And so the Canada Health Act determines what you can and cannot do. And so if you want to call for more central control, more uniformity, more similarity from coast to coast, then you criticize the fact that we have too many systems. It's terrible. It's a disaster. Whereas if you're more of a federalist or a Republican and you believe in state rights or provincial rights, then you celebrate the fact that we actually have at least some diversity based on the population that the system is designed to serve. So it's really, there's a political undercurrent behind the question that you even ask.
Well, that brings up a question that I hadn't thought of before. Is there much medical tourism between provinces? Do people travel to get their healthcare in a different province if they can't get it where they are?
Well, I know you have ties to Quebec, Michelle, so I don't want to say anything bad about Quebec.
That's okay.
So we do see quite a few people coming across from Quebec into Ontario, and we're supposed to have reciprocity. So one of the pillars of the Canada Health Act is accessibility and then portability. And so the idea that you should be able to get the same care in the West Coast as you do in Central Canada, in Ontario. And for the most part, most of the provinces buy into that. And if I resuscitate you in Ontario, I'll get paid whatever Ontario charges for a resuscitation, except if you're a Quebec resident. So if you're a Quebec resident, most people in Ontario would charge you cash. And that's just the way it is. Quebec doesn't reimburse at Ontario rates because Quebec is a nation within a nation, right?
Right. It's a very independent-minded province. You know, it has a strong history of doing its own things, or trying to do its own things.
Yeah.
Probably not always for the better. But so let me start. I want to start with your book, No More Lethal Waits. And the title is seems to be explicit enough. If there was any doubt that weights, can be harmful,
Mm-hmm.
I think you make a nod to that. But on the other hand, what struck me in reading your book, which is really terrific, it's focused on emergency care in Canada. What struck me is that, nevertheless, despite Canada having a single payer system, or even the province being sort of a single and fairly authoritarian in its approach, there seems to be a margin of maneuver for doctors to operate within the system and try to make things better? Because many of your chapters are about, it's advice to colleagues to how about making things work better for patients in Canada.
You're absolutely right. It's just a question of how much time and energy and political capital do you have to be able to create change in the environment in which you work. So great things can happen in spite of the structure that you're fighting against. So some of the things that I talk about in the book are the fact that we have Canadian chaos where incentives aren't aligned to help patients. So the hospitals, up until just recently, actually save money if they care for fewer patients. So that's the concept of block funding. They get, $100 to care for everybody in the community. Well, if more people come, now they're going into a deficit, and that's a bad thing. Doctors, if they are fee for service, they get more money for providing more care. Nurses, if they provide more care, they accept more risk and more work for no more money. So you have all these misaligned incentives, and that's what creates chaos in the system.
Right. Although, it's funny because people talk also in the US a lot about misaligned incentives as well. And one way to align them is to put everybody on a salary, and do away with the fee for service, which you just mentioned, still being operational in Canada, right? Most doctors operate on a fee for service basis,
especially the specialists.
Right. So, but then if we capitate everybody and then it's the patient's the patient's interest to be completely misaligned.
Right.
Well, Shawn, can you just rewind just a tad and give us a sense of what is and is not possible in Canada in terms of healthcare? Meaning, for many folks, is private practice allowed? Are you allowed to be outside of a system that isn't reimbursed from the government? Can you talk a little bit about the differences between Canada and the United States in terms of what's possible?
Yeah, so great question, actually, and it's a little different depending on the province. So up until the mid-1980s, I can speak most for Ontario. Ontario has 44,000 doctors. There are about 100,000 doctors in Canada. So most of what happens in Ontario is a fairly accurate representation of what happens across the country, but it's not exactly. So provinces will differ a little bit. The trend, though, since the 1980s has been a move not only away from allowing doctors to opt out of the provincial insurance plan, but to now make it illegal to practice medically necessary care outside of the provincial plan. So in 2004, the Premier passed the Future of Medicare Act. And so that now if I were to take your blood pressure and you're an Ontario citizen and charge you $25 to do that, I would be breaking the law. Now, that's not the case in every province. And up until 2004, there were a few doctors who were opted out. But even before they were opted out, the rules stated that you could not charge anything other than the government set rates for care. So if you charged more than $25 to check someone's blood pressure, it's actually $33 right now, minus the cuts we've had from 2012 and forward. So if I charged you anything more than $33 to check your blood pressure or to diagnose and treat your congestive heart failure, then I would be breaking the law. Before that time, it was different. So before 1984, it was a little different. I don't know how far back you want to go, but suffice it to say, you pretty much can't practice outside of the provincial system in most provinces. And in Ontario, since 2004, it's now illegal.
Wow.
So what's the reason why the government made it illegal for doctors to practice outside the system? Because, I mean, in a way, you would think that it would be a little bit of a safety valve and provide, better access to care. And what was the reasoning? And especially if the government didn't have to necessarily pay the doctors, right? It'd be a transaction between a patient and a doctor. What was the rationale for that that motion?
Well, the two main pillars, or the two values that people use to defend Medicare in Canada are fairness, and then the ability to receive care regardless of your ability to pay. So they believe that Canada believes in fairness, and so everything needs to be totally fair for everybody, and also you need to get care no matter what your ability to pay might be. The problem is that we know that that's not true. So I'm looking, we've known that for 20 years now. I'm looking at a New England Journal of Medicine article. I'll read you. You can't see that on the video there. This is going back to 1999. The effects, and you'd like this as a cardiologist, Michelle, effects of socioeconomic status on access to invasive cardiac procedures and on mortality after acute myocardial infarction. And what they found is that there was a 23% increase in rates of use and a 45% decrease in waiting times for those people who lived in the highest quintile neighborhoods. So although one of our values is, no matter how rich or poor you are, you all get the same care, we know that that's not the case. And we've seen that, and there are many other studies like this than the one I'm quoting you from the New England Journal. I have other studies on the desk in front of me. And so we've lost the moral high ground. We know that people of the lowest socioeconomic status have the hardest time accessing care in Canada and some of the worst health outcomes. And so what it begs the question is, why do richer people get better care? It's not because they're sliding $5 across the table. It's because of a whole system of patronage and privilege. And I talk about that in my book. If you're smart enough to earn lots of money, you're also smart enough to know that Michelle's going to give me an angioplasty faster because I know how to talk to him. And so I'll stop there. But we've lost the moral high ground on fairness and care regardless of your ability to pay.
Right, but that could be an argument for the government to intervene even more and say, listen, you really can't act that way. We're going to put monitors everywhere and make sure that these discriminations don't take place.
And that's what they did. So exactly to your point, you're absolutely right. And that's why in 2004, the Ontario provincial government kicked it up even a notch. And they said, now there's a $25,000 fine if anyone can prove that you jumped the queue or you helped someone jump the queue, the wait time, right? Standing in line for a procedure. And on top of that, now it's illegal for anyone to work outside of the system. But as you and I know, was it Tacitus who said that, the worse the society, the more the laws, right? So you can't fix this with more laws. You have to align incentives. At least that's what I believe. Happy to debate that, but that's
right. I think that's correct, and it's a great debate. But I'd rather focus right now on the mechanics of the healthcare system, so we understand them in Canada. Sorry, Anish, just one more thing. So after they passed that law, access got worse, presumably, or do we know that for a fact? Once they stopped doctors from providing healthcare outside the system, did it impact on wait times?
So great question. So just to be clear, very, very few people were opted out even at that time because there was no benefit to opting out. You couldn't charge more. So you still had basically I think it was a few hundred, maybe even less, maybe a few dozen, mostly psychiatrists who were opted out. They were opted out on principle. So they would give their patient a bill, the patient would submit it to the government would pay the patient. Many more people were opted out in the 1980s, but once the government ruled out, doctors called it balanced billing in 1984 and previous. But the media called it extra billing, of course. And the reason for that is back when they started the insurance program, they basically took our doctor's schedule of fees and said, well, now you're going to get 100% of your bills paid. So we will reimburse you at 90% of the rate that you used to bill, right? So we'd had a provincial fee schedule, and the government said, well, now we're going to pay all your bills for you, but we're only going to pay you at 90% because you're going to have no bad debt. So it started out at 90%. Now it's around 45 to 48%. So the amount that they reimburse, and we've only increased our fee schedule with inflation since the early 1970s.
Right.
So when that gap started to happen in the early 70s and 80s, doctors were actually saying, okay, the government's not keeping up, and so we need to ask for $5 or $10 from our patient. As of the Canada Health Act in 1984, they made that illegal too. And so, but already by that point, most people were not practicing outside the provincial systems because it was no benefit. It was just
Right.
an irritant for your patients.
So the act was primarily symbolic, just to say, I don't know, it didn't have much effect. But certainly, access to care has deteriorated since the 1980s, right?
Yeah, absolutely.
And that's both for hospital care and for outpatient care?
That's correct. So I can give you a few statistics. For example, again in Ontario in 1990, we had 33,403 acute care hospital beds. That's in 1990. In 2017, we had 18,571. So 33,000 down to 18,000. And in that time, our population grew by 36%. And in fact, if you go back to the 1980s, you and I were talking before you started recording, but if you go back to the 1980s, there were even closer to 40 or 50,000 acute care beds. You could argue that we had too many beds. Maybe there was a glut of beds. But if you compare ourselves around the world, we currently have 2.3 acute care beds per 1,000 population, which is 32nd place in the world. Germany has 8.2 beds per 1,000 population. Japan has 13.7 acute care beds per 1,000 population. So it's pretty hard not to have people waiting when you cut the number of acute care beds down to 2.3. In Brampton, a large city just near me, last year they had over 4,300 patients cared for in the hallways at Brampton Civic Hospital. That's only one hospital. 4,300 patients in a year. So it's very possible to get admitted to the hospital and spend your whole time in the hallway. Or in Sudbury, there was a patient who was admitted to a washroom. There was a toilet.
You know, I was joking. There was a similar story coming from the UK, and I said, you know, we've in the US we've implemented the practice of hospitalists, but in the UK they have hallwayists.
Yeah,
right?
That's right. That's good.
That's good. Making hallways great again. I like that slogan. What? So the interesting, you know, in the NHS is a little different in that I guess one of the fathers of the NHS, aneurysm. Sorry, I'm getting his name wrong.
Aneurin Bevan.
Aneurin Bevan. Yes. He famously talked about stuffing the physicians' mouths with gold. So meaning allowing a very robust private system to private practice system to exist. Kind of to appease the doctors. Why? So, you know, it sounds like, you know, it was very hard to get buy-in from physicians otherwise to move towards this system.
Yeah.
Why are Canadian doctors so willing to go along with these fascist things?
Sorry, are you criticizing me, Anish? Am I supposed to smile at that?
It's the other Canadian physicians, not you.
No. So, and I think you say his name, Aneurin Bevan, Bevan. Yeah. And I believe his comment was in reference to a question where they asked, you know, how did you get these doctors to buy into state medicine?
Yeah.
And he said the way I did it was I stuffed their mouths with gold.
Right.
And indeed they did the same thing. I mean, I think of a good example with primary care reform right here in Ontario in 2004 and following. The government really wanted to go to a capitated care model as they've done in other countries. And as you know, when you move from a fee-for-service system to a capitated system where you get paid, you know, $100, $150 to care for a patient all year, it shifts the cost risk to the doctor. So the doctor now has no incentive to see that patient more and more and more, whereas before in a fee-for-service, you're incentivized to see more and more. So to get doctors to sign up to that and give up their right, if you want to call it that, or give up their duty to see patients only when patients need them and to provide as much care as possible to patients, they made it so attractive that you'd be crazy not to jump on to a capitated system. And a similar thing happened in the when it started between 1968 and 1972, but it's not as simple as it sounds. So in 1962, and all the pundits love to rub this in doctors' faces over and over, everything would be great in the healthcare system if doctors hadn't gone on strike in 1962. And that was the famous strike of 62 in Saskatchewan, where they went on a 23-day strike and they called in docs from the UK to try to backfill. And that was really where things came to a head in 1962. So I think it's safe to say, I don't think doctors have been overly enthusiastic about the system until they started to see their paychecks in the early 1970s. So if you look at the paychecks that docs were getting under the socialized system in the 1970s, the incomes just skyrocketed. But just like Milton Friedman says, if you ever look at his video when he spoke to Mayo, and I think in around 1978, he said, government always wants to sweeten the pot when it wants to do something new. It'll pour in money, get all sorts of support for their new system. But once there's support, once they've got their new system in place and there's no more political goodwill to be earned, they'll shift those resources to a new project. And so that's what we see in Canada. So it started out as an insurance system. They started then limiting care, closing beds in the 80s, and then in the 90s and following, it became more of a managed care approach. And now we're almost into an HMO kind of feel. So it's morphed over the years.
So are primary care physicians now on a capitated basis, or
more than 50%? There still are some that are fee-for-service, but the fee-for-service payments have really been flat. So the main bill, like if I see you for congestive heart failure, pneumonia, whatever, $33, and that hasn't changed for 15, 16 years. In fact, it's gone down.
And when in the fee-for-service world, whether we're talking about whatever primary care physicians remain on that system, or specialists who are on that system of fee-for-service, has there been an increase? What we saw here, when fee-for-service price ceilings were instituted, beginning in the early 1990s.
Yep.
It's been the churning, so volume increased. So
factory medicine,
right? Is that happening, or
yep.
There's not even a yes?
Yes, absolutely. So fee-for-service, most consultants are still fee-for-service. There are very, very few who are salaried. Often they're in academic settings, or if they're doing a lot of research. But for the most part, consultants are fee-for-service, and family practice is considered, or primary care is considered to be the gatekeeper of the system. But there were individual physician caps placed in the 1990s, and so you could only earn, X number. I think it was around 300,000, and then after that, you really didn't make much at all. That sounds terrible, but it was actually better than a global cap. So an individual cap, at least you knew how much you were making, and then you could just go on holidays, right? You could say, all right, I'm done. I can't pay my office staff. I'm laying them off. Whereas a global cap on the total number of physician services, so in Ontario it's about $12 to $13 billion, if the government refuses to fund that above, let's say, 1%, even though utilization is 3.5%, now you have all the rats on the ship trying to fight for the same pot of food.
That's worse. Right. And that makes sense, because I was trying to figure out why, because one way, at least, one way that doctors can try to make better income here is to open outpatient surgery or procedure centers. And so, but if they're capped in their salary in Canada, there's not going to be much incentive for them to do that. Am I understanding it correctly?
You're absolutely right. And in fact, in Canada, you have to get a license to open up those extra clinics. And so, for example, if you have a diagnostic services, so you want to do echoes, right? And you want to do imaging, cardiac imaging, you need to have a special license to be able to open that. And so it creates a market for these licenses. They're maybe only worth $1,000, but to sell them or buy them, they're worth a few $100,000. And there are rules about it depending on the area you're in. And then there are rules about how close you can open your clinic to a hospital, because the hospital has to have those services. So you're not allowed to open the diagnostic imaging services right across the road from a hospital, because then you would undercut the amount of services that they could provide. And so there's a whole bunch, like I said, privilege, patronage, right? You need, who do you know, how can you work the system? It's like any overly regulated system.
So how are obviously the one of the things that must be the case, because I mean I keep getting hammered with these hard outcomes in terms of life expectancy, infant mortality, etc., that Canada is no different or better in all these different hard metrics, right? So it must be the case then that there was a massive amount of overuse, or it must be the case that we should be treating more patients in hallways. I mean, what is the meaning? How do you explain it? Clearly, the systems that have been set in place have worked in terms of decreasing utilization a significant amount, and also controlling price. And with controlling price comes, of course, less supply of doctors, less acute care beds, etc. Yet you have not opened up some massive gulf in terms of life expectancy or mortality or hard outcomes. How do you explain that?
So great question. And whenever people start saying, oh, but we beat the United States on infant mortality and we beat the United States on cardiac mortality, well, I think we're comparing apples and oranges. If you have a whole bunch of people in a particular socioeconomic class who maybe don't have a ton of prenatal care, your infant mortality might be very different than you have in a more uniform population who has sort of a more uniform access. But I guess I direct you to the Commonwealth studies of 2014 and 2017. You're probably familiar with them. You've seen this colorful chart. This is in black and white. And so, we were all cheering in 2014 because we were the second from the last. We beat the United States, right, on access, quality, and cost and all that. And then in 2017, the same study, Mirror Mirror from the Commonwealth Fund, we had dropped to third last. So now France was second last behind us. But to your point, where do people go for care in the world? If you can afford it, you go to the United States. Who does all the research and development? The United States. Who benefits from that? We do. So it's a bit unfair for us to sit back and say, oh my goodness, you guys spend so much money on care and research and marketing, and you develop these wonderful products and treatments. We get to use them, but we're much holier than you, right? Because we don't spend all that money, but yet we get to use it all. So there's a disconnect there.
I'm so glad you're making that point, because it's we've been making it, but it's coming from you. It carries more weight than coming from us. So how are the doctors? You've been a leader. You may be still involved in the Ontario Medical Association. What's the feeling among doctors? Are they resigned and for the most part passive, and they just want to keep coasting until they retire and that's it? I suspect young doctors must be a big issue for them to confront the prospects of Canadian healthcare. What's your feel on this?
Well, it depends which study you look at. So if you look at the recent Canadian Medical Association study, it's from coast to coast of all physicians. I believe the numbers, and I don't have them right at the tip of my fingers, but I believe it was 50% of doctors show signs of burnout on the survey, and I believe 30% screened positive for depression. Now, maybe doctors are just all very sad and the system has nothing to do with it. But I don't think that's the case. Certainly suicide rates are over 2 times other professions. new graduates are finding it really hard, but more anecdotal evidence. So as president, as I traveled around the province, it was not uncommon to hear from new residents in practice saying, Shawn, what do? I just heard from my bank and they told me I am not going to make my loan payments because the government just cut us again with no warning. They just cut us another 2.5%. I just renovated my practice. I've got $250,000 of educational debt. And I was already right at the line when I got my line of credit. That it was touch and go, but they said, you're a doctor, we'll fund you. And now the government's cut you. And then the government cut you again. So we've been cut in Ontario every single year since 2012. Every single year, our fees have gone down, down, down. So on average in Ontario, doctors' net income is down over 30%. So we are in a massive, massive hole that I don't think any government can get us out of. So it's very difficult to separate the fiscal reality from overregulation, from more demanding patients, more complex chronic illnesses, maybe physicians who, maybe I'm not as tough as the docs were 30 years ago. Maybe they were a different breed, right, where this didn't impact them. So I think the literature is very strong, though, to say that if you select for people who are caring, type A, hardworking people, and then you show them no respect, you heckle them in the legislature, you slander them in the media, and then you ignore them for multiple pieces of legislation that directly impact the way they can, or their ability to provide care for people in need, it makes it very hard to avoid burnout, demoralization,
right,
and people wanting to retire.
And it's very important for you to remind us that, even in Canada, where it's a single payer system, it's got a lot of uniformity. The government cannot run the practices, so the practices are still owned and operated by doctors who are small businessmen and who have to deal, to act as such. I mean, they have employees, they have to make payroll, they have to do all this. So it's not that they're taken care of by the government being able to, paying predictably the bills.
Right. And so I'm glad you mentioned that for two reasons. So number one, the point you made is brilliant. So I am a small business owner. I'm sitting in my little old clinic right now. It's an old house that has a few rooms in it. I have staff that I pay, rent, hydro. I have no pension, no benefits. And so just like any other small business person, I have to run a small business. But on top of that, if you could imagine someone opening a lemonade stand, right? You have your son and daughter, they open a lemonade stand we were talking about before we started. Right. So imagine if they had to apply for a license, and then they had a list of rules on the temperature of the lemonade, how many ice cubes could go in the lemonade, and they weren't allowed to make their own ice cubes. They had to actually go around the corner to another stand to get their ice cubes, and they couldn't sell napkins. They had to get those from somewhere else too. So you get to a point of, at what point do you say, okay, well, you own the practice and you have all the responsibilities, all the overhead, but really the number of decisions you make are smaller and smaller and smaller. So at some point you have state funded, but also the state has such a major say in everything that you do that at some point we have to say the emperor has no clothes and really question, is this truly private practice? Because those of a certain political ilk love to say, oh no, it's publicly funded, it's totally private, it's your practice. But we all know that's not the case.
I love this analogy with the lemonade stand. I don't know if it's in your blog, but I just want to draw attention to the audience's attention to your blog, because your blog is full of stories like this with great analogies, and great stories about how it, how it really is. You had one recently about the Muppet show. So your blog, we'll put a link to your blog on the show notes.
Thank you.
By all means, I want the audience to check it out. It's really humorous and fun, but it's insightful at the same time.
Well, one of the things that I've noticed is that, I mean, this type of pressure that's been applied on physicians should be unifying physicians, hopefully, to resist, if you will. But and then that the type of pressure that's been applied in the United States would also be making physicians resist in a type of unified, organized fashion. But of course, that doesn't happen. And the other side, whether trying to or not, is very effectively able to split us. And that happens in the United States all the time. And it appears to be happening even in, I don't want to get this wrong, and I think in Ontario, where I saw a list of high-paying specialties and low-paying specialties, and everyone is getting riled up about the folks that are making lots of money, and the family physicians are like, let's tear those guys down. The Schadenfreude that kind of is very easy to muster and instill in folks. That seems to be, is that am I right in saying that it appears that physicians in Canada aren't kind of unified and in terms of seeking better access for patients, better remuneration, better conditions to practice in, etc.
No, yeah, great question, and certainly the term we use for it in Canada, and I think they use it around the world, is relativity. So, is the work that you do relatively more valuable than the work that I do? So, is it worth more to reduce your pulled elbow, than for me to resuscitate someone who's dead and now they're alive, right? I get $75 to do that, but the orthopod reduces someone's hip, or I reduce someone's hip, and it's $150. So is it worth twice as much to do 15 seconds of work, pulling a hip back into joint, versus intubating someone and running a code and getting their heart restarted, and now they have spontaneous return of circulation? So this is a problem that no one has figured out all around the world. So relativity is poorly done around the world. I think the United States is doing better with relative value units than we're doing, but certainly right now we are at the cusp of a major fight over relativity. And it's sad when you have a fixed pie, people care most about the big eaters. So I care most if your piece of the pie is bigger than mine. And so you'd hope that it would pull people together. It really takes a particular kind of leadership to say, listen, these are our principles. This is why we're here. Representative democracy, or as Aristotle called it, polity, is actually a desire to serve based on the best interests of the people that you're serving. And the poisoning or the corrupt form of polity is democracy, and that's direct democracy. And as soon as you have direct democracy, well, people can hide behind a secret ballot and say, I'm going to steal money from Michel because he's a cardiologist and he makes so much more than me. Well, that's not a principled approach to pulling people together and saying, we are here in this bad situation, not because Michel makes more than me, but because the government has designed the system such that we have a fixed pie and we can't actually do what's necessary for patients. So a huge question you've asked. It's a huge issue right now in Ontario. It's kind of a sore spot. We had a special meeting yesterday about it all day. And so I'm glad you asked the question.
Well, I'm glad you're the voice of sanity to really at least, provide that perspective that people have lost. I mean, it used to be prevalent in our countries, in the US, and in Canada decades ago, and it's been lost.
Yeah.
Any hope? Do you see any movement that's more favorable to sane and fair market principles? I see, I read sometimes about Canadian think tanks, but think tanks are, people, policy people and people who are far removed from the day-to-day activities of doctors. But do you see any hopeful signs? I see some in the U.S. On a practical level, but I don't see much in Canada.
No, right now, so only 4% of the population needs acute care in any given year. And so 96% of the people in Canada are living on the dream. They live on the dream that if I get a broken ankle, I get care right away, or I'm going to get care just as fast as you are, because we give care regardless of ability to pay, and all these values that the one side keeps pounding over and over. But it's only until you actually have a lump in your groin and you realize that you're waiting 2, 3, 4 months for imaging. And so you're sitting there wondering, well, what is this thing in my groin? Can someone please just biopsy it tomorrow, not in 5 months from now, and longer? Or living with your hip, you're using a walker and you're waiting almost 300 days for a hip replacement. That's after you've already waited in pain, seen your family doctor, been referred. That's after the surgeon says you need a hip. Now there is some glimmer of hope. I don't mean to be completely negative. If you get hit by a car on the side of the road and you're bleeding to death and you get whisked into the emergency department, you probably will see a trauma team. Or in our area, we do have a helicopter, and a helicopter will come and take you down to a trauma center. And I think our outcomes for acute trauma are probably comparable worldwide, or when you actually do finally get your cardiac bypass surgery, our perioperative mortality rates are good, and our time back to, our length of stay in hospital is good once you actually get your care. So there are some bright spots in the Canadian healthcare system for sure. But you asked specifically about system change. And what we need to do is reassure people that the sky will not fall if we try something different. So a leader in this right now is out in Saskatchewan, Premier Brad Wall. He designed a system or proposed a program where he would offer one, I believe it was a CT or an MRI, I can't remember, maybe it was even both, but anyways, one advanced imaging test in a private lab, as long as you did one imaging test on the public list at the same time. So it was a 1-for-1. And they found that wait list drop on, radically. The sky didn't fall. The public was happy because wait lists were less. You didn't all of a sudden have this glut of people in Rolls Royces that were getting great care and everybody else was dying on the streets. Like, none of that happened. And so I think if we can chip away and say, why are we so ideologically wedded to Medicare instead of patient?
And identifying potential solutions. I hope you continue to be involved in leadership. I think people need you. Are you? You were the president of the Ontario Medical Association.
Yes.
Are you still active?
Well, for this year, I'm still on the board as past president. And just to be clear, I'm not speaking in my capacity for any organization. I was on the board of the Canadian Medical Association as well. I have just now joined as a Monk Senior Fellow in Healthcare for the Macdonald-Laurier Institute, which was recognized as Ottawa's top think tank a few years back, and still very active, despite your comments about think tanks. I won't take that personally. But I think real change happens when, I think it was Pascal who said, a lot of people won't want your idea to be true because they find it to be scary. And so they're scared that what you say will be true. And so it's our job to offer evidence, but more importantly, we need to show that the ideas we're talking about are attractive. And then people will have the evidence and they'll see that our ideas are attractive, and then they'll want them to be true. And so we have some work to go there. I don't think just straight arguing right up on principles or Hayekianism or
No, I agree, and it's what's happening in the U.S. At least the U.S., despite its terrible flaws, because it has flaws that are very severe. They are different from the Canadian system, but they're equally severe and pernicious in my mind. But at least there's a greater margin of maneuver, so that now people can lead by example in certain niche areas. As you were saying, you were giving the example of doing something in Saskatchewan, chipping away. And that's what's happening here in the outpatient arena with a direct primary care movement, with outpatient surgery centers, things like that. So there's a way to try to give examples. I mean, it has to be lived, as much as possible.
Yeah. Well, the general pattern on rescuing the Canadian system up until now has been, we get to a point where things are getting bad, so the government pours in a ton more money and kind of resuscitates the system for a little longer, and we hobble along. But eventually you can't put that much money. So economist Don Drummond, again, 2003 or 2004 in the Drummond report, said that in the next 20 years, I believe it was 20 years, I don't have the exact date, but he said that the provincial budgets will be spending 80% of their provincial budgets on healthcare into the 2030s if we keep spending at the rate we're spending. So you get to a point where you just can't keep up with a first dollar coverage single payer system. And actually there are many similarities between your system and ours. It's just that your single payers are they're paying a lot more attention to what you guys do. And so they hammer on you harder to make sure that you're not doing what they don't want you to do. But ultimately someone else is footing the bill and writing the regulations.
Yeah, we had Adam Gaffney on, who's a big proponent of single payer healthcare. And this is one of the points that comes out even with a bright, well-read guy like Adam. Is that look, there are none of these systems that are single payer first dollar systems like you're talking about, like Canada is. They are not in the long term a solution to helping tamp down costs. So everyone talks about, oh my goodness, the United States is spending 18 to 20% of their GDP on healthcare. This is unsustainable. The only way to fix this is with a single payer. You find me a single payer system out there that isn't draining a vast majority of its resources and putting it into healthcare, right? Yeah. None of these systems are sustainable. And the only thing you get in response from honest guys like Adam is that, well, we'll have to raise taxes, and be ready for, 70, 80%, whatever it takes. The taxes will have to keep going up in order to support this system. But the idea that so many in the United States hold, so many physicians in the United States hold that somehow single payer is going to be some type of panacea that's going to solve the problems with access. It's going to solve the problems with inequities in care, and that are going to solve the problem of cost. It's just this is not true. What you're saying is I think is so true, and something that is an important point for folks to learn is that, or to understand, is that you almost need some type of a hybrid system, right? And that is probably the best system, some type of cobblestone together system that hopefully avoids some of the crony capitalism excesses.
For a compromiser like you, yes, I'll accept a hybrid system. So weak.
Well, certainly the literature suggests that we in Canada have lost the moral high ground. There are dozens and dozens of articles. I can send you a reading list if you like, showing that we've lost all of these wonderful goals of inequity. I agree. We need to get care to our neediest patients, and it's because of that I believe a single payer system is not going to get us there. And now, just to be clear, there probably are areas where we need the government to really be, let's say there's no opportunity of a market, maybe transplant care or trauma care. I don't know, but let's have a discussion about it and say, which areas do we really need a major having the government be a major player, and which areas do we have now a true market? We have enough information, we have a true variety of services, we have a great access where you can actually say, okay, you know what, patients aren't as stupid as we think. They actually can make decisions, and especially if they're not under the gun bleeding on the side of the road. And so there are opportunities where they're making decisions right now anyways, right? They'll ask for second opinions, and they'll come to me saying, hey, I need an MRI of my knee or whatever. And so we shouldn't underestimate the intelligence of the people that we're providing care for. And I think they could make a lot more decisions than we give them credit for.
Michelle, you're causing Michelle great pain right now.
Yes, I think there's a role for government. I think it's in the entertainment industry. I think they're irreplaceable there. But in healthcare, I think I'm pretty confident that we can do away with government intervention altogether.
What about transplants?
That too. Yeah. There's no when you go back to first principles, there's no reason why the market couldn't provide transplants, and right now it does. Government does it very poorly. Certainly, I mean there are waiting lists and whatnot, and ethically in very problematic ways.
Right.
That gives me. Maybe we should do a show on that. I would
love to. So I debate with my very pro-market friends. Maybe we needed the government to provide telephone when there was no business in their right mind who would provide telephone up to Elliott Lake or to Churchill, Manitoba. And my friend says no, but they would, and so we go back and forth. I hear the arguments on both sides, but I think the argument to say that government must do everything completely falls down as soon as you have any kind of population base and you have transportation services like we have now, communication services like we have now. You just can't say that we have 10 people on an iceberg in northern Canada that no business would ever go and service, therefore we need government health care. Okay, I can buy into that for that one case. But that doesn't really exist anymore. And so let's have a discussion like you're saying. But I don't know if I go as far as you, Michelle, although I love the fact that you're going there.
Well, maybe we'll have you back. Maybe I'll be able to work on you a little bit more next time.
You'll convince
Shawn,
me.
I want the audience to have a chance to follow you, and we'll have this on the show notes. But for the people who are listening, a Twitter account, a blog, where do we follow you?
So I'd love it if you checked out my blog. It's just ShawnWhatley.com, and that's ShawnWhatley.com, and that's just my blog. Please share comments, sign up. Twitter, I'm Shawn_Whatley for my Twitter handle, LinkedIn, all the rest. I don't do Facebook too much, but yeah, no, I'd love. I try to pull out debate. So I try to say something that'll irritate you enough to say something, but in a kind way. I'm not here to embarrass people. I want you to respect your dignity. But unless we can, so the opposite of hate is love. The opposite of love is not hate. The opposite of love is apathy. And so if you can find someone who is angry at the things that you're saying, that means they care about the topic. And so I think we're far better off trying to engage with the people who have passion than trying to get the people who have no passion to care about what we're talking about. If they have no passion, that is truly the opposite of love. They could care less about things. So if we can go to the people who actually really have feelings, strong feelings about these issues, I think at least we can get a dialogue going. Now, maybe that's my rose-colored glasses, but that's the way I think.
No, I think it's very well said, and this conversation gives me a lot of hope for Canada. You do have a large following, and I suspect you're right. I mean, people understand that this is unsustainable, and they can hear a sensible voice to show the way forward. So, Shawn, thank you very much for joining us.
Thank you, Michelle, and thank you, Anish. Is wonderful. I really appreciate what you guys are doing.
Thanks. Really great having you on.
Okay, bye now.
Yep.
Take care. Bye.